Hey guys, how are you all? Welcome back to MedSteps YouTube channel. So today in this video we are discussing about very high yield topic and very common in our medical field. Every time we are seeing in our orthopedic department and accidental emergency department with like many times we are seeing this type of distal radial fractures. So our topic is distal radius fracture. This is very important topic. So in this video we are discussing like both theory and clinicals practice, how we can manage that patient. Like this is very important for NEET PG students, FMGE and USMLE etc. And so let's go. Distal radius fracture means in that radial bone, in distal part, that fracture is happening. Okay, so distal radius fracture. So we are discussing from basic to advanced stage. Okay, so first, what's the definition? Distal radial fracture involves the radius within 2.5 centimeters. This thing is very important. In distal radial fracture, the fracture involves in 2.5 centimeters of the wrist joint. Okay, and this thing most common upper limb fracture, especially in elderly. In elder means if any patient have like osteoporosis patient, in young maybe high energy trauma can occurs this type of fracture. Okay, so now before going to topic, we have to understand the main important is anatomy. Without knowing anatomy, you can't read the X-ray and you can't diagnose this fracture. Okay, because based on fracture only we can do the management. Good. So now in anatomical part, first what are the bones included in distal radial fracture means first one radius and ulna. Mostly we have to focus on this distal 1 by 3rd of radius. Distal 1 by 3rd of radial. Okay, this radial bone, if you are seeing this bone, this is radial bone, right? Distal part. This radial bone is articulated with two carpals, that is scaphoid and lunate. So this part we call, that is the radiocarpal joint. Okay, this radius distal part is articulating with scaphoid and lunate. So this joint we call radiocarpal joint. Okay, so when it's coming to ulnar, this ulnar means this is ulnar bone. This ulnar bone is distally attached with this carpals. So we call this is distal radial ulnar joint. Okay, why I am focusing in these two things, because this is the main things for fracture. If any fracture happen means we can see some angle here, some gap in between these joints. Okay, so that's why I am focusing, mostly I am giving some time in this area. Okay, so I am repeating another time. The radius bone is distally like 1 by 3 of radial, is attached articulated with two carpal bones, that is scaphoid and lunate, and this thing we called this joint we call radiocarpal joint. And ulnar bone, it's in distal part we can see some it's attaching with some articulating with some of the carpals. That part we call distal radial ulnar joint. Okay, so now some anatomical landmarks. If you are seeing this image, you can see here one ulnar styloid. What is this ulnar styloid? This ulnar styloid, you can see this total area. I am highlighting this area. This area we call distal radial ulnar joint. It will give stability. Okay, what it will give? It will give the stability to that radial and ulnar, that wrist part will get stability with this ulnar styloid. Okay, next, so here we have to understand some Lister's tubercle and dorsal radius. It's a key surgical landmark. So with the tubercle, based with the tubercle only we can do that surgeries. Okay, we will discuss in management. And the styloid process of radius, it's very important in Colles fracture. And this ulnar notch of radius, this is a part of you can tell ulnar notch or ulnar styloid, both are same. Okay, it will give the distal radial ulnar joint, it will give the stability. Okay, now if you are seeing this image, this third image, you can see here this ulnar styloid will give stability. I already mentioned that thing. Now we are going to discuss about some TFCC. What is this? TFCC means it's a like triangular fibro cartilage complex. Okay, what is this? This is one type of cartilage. Why? Because we call this thing is a group of ligaments. Okay, this group of ligaments that and cartilage located between the ulna, lunate and triquetrum of bones of wrist. Okay, so what is the what uses, what it will do? This triangular fibrocartilage complex functions are total. Yeah, this thing will help for four things. First one, this thing will stabilizes the distal radial ulnar joint. Okay, and it acts as a cushion, and it enables smooth wrist motion, and main thing, it provides ulnocarpal stability. Okay, so this is the main thing for we have to understand. This TFCC we call triangular fibrocartilage complex of complex. It's like group of ligaments and group of cartilage located between the ulna, lunate and the triquetrum bones of the wrist. Okay, so here what are the functions? Main important functions means it's like we have many functions, but I am telling like important functions only. It can stabilize the distal radio ulnar joint, and it acts as a cushion, and it enables smooth wrist motion, and it provides ulnar carpal stability. Okay, mostly this TFCC injury we can see in athletes and fall on an outstretched hand, and some if any patient have some degenerative changes in elder people, we can see this type this triangular fibrocartilage complex ligaments injury. Okay, so now we are going to discuss very important things. In this thing is very important in X-ray, so that time I am not going to go little deep. So here only I am going to tell these things. Next one, radial inclination. Radial inclination means mostly we can see that is like 22 degrees is the normal value, but what is main important, why we have to check this radial inclination means this angle, we are checking the angle between a line in perpendicular to the long axis of the radius and a line along the distal radial articular surface. Okay, every time we have to check with posterior anterior view of the wrist. Okay, so why, what purpose we are checking this thing? If you are seeing this image, you can see here this is the radial inclination, we already marked here. This is the radial inclination, we can see this is 15 to 25 degrees, like 22 degrees is the normal value. Okay, so in clinical relevance, in clinical clinically if you are seeing means This radial inclination indicates radial collapse or lateral displacement. If that normal value like 22 degrees, if it's decreased means like normal range is 21 to 25. If it's decreased means then we have to suspect it indicates radial collapse or lateral displacement. Okay, that reduced angle, it's maybe indicates malalignment or malunion. Okay, and mostly it impacts wrist biomechanics in movements, in range of motions, these things. Okay, so this thing is very important for diagnosing the fracture and that interpreting the X-ray. Okay, next we are going to discuss about radial height. This mostly we can see that distance between two horizontal lines in posterior to anterior view and the across the tip of the radial styloid. Okay, tip of the radial styloid to from radial styloid to another line at the level of the ulnar corner. Okay, and another line we can see the ulnar corner, and we can tell that is the lunate fossa also. So normal value is 11 to 13 mm. Here why we are checking this radial height means are also called, you can call radial length also. So if this decrease in radial height, its significance for impaction or compression fracture of the distal radius. Okay, and another thing here, if it shortens greater than 5 mm compared to contralateral side, then we have to it indicates the surgery. Okay, next volar tilt, you can tell volar tilt or palmar tilt, both are same. This is, we can see that line is drawn perpendicular to the shaft of the radius and a line along the articular surface of the distal radius, and this is we can measured with only lateral view of the wrist. In normal value we can in normal value like 11 degrees plus or minus to 5 degrees, like normal range is 10 to 15 degrees. Okay, if it tilts anteriorly means then we have to think that is the volar. Okay, so in dorsal angulation the negative volar tilt occurs in Colles fracture. Okay, when we are discussing about Colles fracture and Smith fracture, I will try to give you like deep explanation. If the tilt becomes neutral or dorsal, it affects wrist extension and load distribution. Loss of volar tilt greater than 10 degrees from normal is an indication like we have to do for that thing reduction or surgical fixation. Okay, so this is the things very important for our diagnosing the bone. Now biomechanics. In biomechanics the load transmission mostly 80% of radius will take care and 20% of ulnar. Okay, so in biomechanics malalignment affects wrist and forearm rotation. If any person got surgery or fractured bone, if after surgery we have to encourage that wrist and forearm rotation, because mostly they will get problem with this rotation and these things. And why we have to think, because some soft tissues are attaching to the this radial and ulnar bones like pronator quadratus anteriorly we can see, and brachioradialis tendon, it insert at the radial styloid, it can displace fragments. If any person have extensor compartments like overlay the dorsum, important for dorsal displacements. Okay, now we are going to discuss about some Classifications. We have total 3 classifications. Now we are discussing the first classification, that is Frickman classification. It's based on involvement of radiocarpal joint and distal radioulnar joint and ulnar styloid, not widely used today, because it's this Frickman classification we used before many days ago, but now we are not following this thing. Okay, so we can see radioulnar joint and lunate fossa and sigmoid notch and scaphoid fossa also. Okay, this is the classification. Here mostly we are seeing the space in between these joints. Next one, Fernandez classification. It's based on mechanism, or based on that injury type, like bending fracture and shearing fracture, compression fracture, avulsion fracture and combined fracture. So based on mechanism of injury, we can think that is the we can easily tell, based on the Fernandez classification we can easily find out the that mechanism of injury. Okay, next one, assessment of orthopedic are based on orthopedic trauma of the association. Mostly we are most widely using this type of classification. We have total 3 types of classification, that is type A, type B and type C. In type A, or we can call that is type 1. In type 1 we can see some extra articular. Articular means we can think about that is the joint, but here that out of the joint, if any fracture happened, in distal part like this, then we can tell this is the extra articular fracture. If any fracture happened in distal part, we can tell that is the type 1 extra articular, and this thing also in lateral side. In type 2, simple intra-articular, that means it's going in between the articular. Okay, this one, and extra articular, intra-articular both. This type of fractures will comes in type 2. In type 3, complicated intra-articular, that means mostly that cartilage will break, that disruption and this breaking will happen here. Okay, so this is the type 3. Next, mechanism of injury. In mechanism of injury, we have total. In mechanism of injury, mostly I already mentioned, it's most common in elder old age people, like mostly females, like osteoporotic bone, and in young adults, so we can say high energy trauma, and most commonly due to fall on outstretched hand first, common in elderly, like I already mentioned, and high energy trauma in young adults, that is MVA, like vehicle accident, and dorsiflexion and radial deviation leads to Colles fracture. Okay, now this mechanism decides the type of fracture. For example, Colles fracture. Colles fracture, now we are going to discuss about types of distal radius fracture. Here, first one, Colles fracture. Mostly Colles fracture means this is dorsally displaced and classic elderly fall, or distal radius fracture occurring within 2.5 centimeters same to same of the wrist joint, and characterized by dorsal displacement, dorsal angulation and radial shortening of the distal fragments, and typically resulting from a fall on an outstretched hand with the wrist extension. Here this is extra articular, and this is most common. You can see dorsal angulation, and you can see dinner fork deformity sign, and radial will be shortening, and common in elder, and is associated sometimes with ulnar styloid fracture. And because of this Colles fracture, we can see sometimes medial now injury. So if you are seeing this X-ray, if you are seeing this X-ray, you can see this fracture is This fracture is, we can see in distal radius and extra articular. Okay, distal radius and extra articular. Dorsally displacement and angulation of the distal fragments and may be associated with some ulnar styloid also, styloid fractures also. This is the anterior posterior view and this one lateral view. Okay. Yeah, this is the Colles fracture. You can see this type of hand, like wrist extension, and this is like dorsal angulation or wrist extension, and you can call this is like Colles fracture. And mostly why this thing happening, because first fall on an outstretched hand, or you can call, you can see like dinner fork or silver fork deformity. Okay. Next one, Smith fracture. Smith fracture, like it's like a fracture of the distal radius with volar or palmar displacement and angulation of the distal fragment. This is the volar displacement, anteriorly displaced or anterior angulated and garden spade deformity we can see. Okay, and mostly we can see this fracture in younger individuals due to high energy trauma or fall on flexed wrist. Okay, if flexed wrist means we can think this is wrist fracture. If outstretched fracture means Colles fracture. This is very important for your exam like NEET PG, FMGE and this type of exams. Okay. Next, if you are seeing this X-ray, in this X-ray you can check that, like, okay, yeah, you can see the fracture of the distal radius, like some displaced fracture, volar displacement and angulation of the distal fragments. This is the lateral view. Okay. So mostly this fracture you can see because of fall on flexed wrist. Next, Barton's fracture. In another thing, in Smith's fracture you can think about like reverse diner fork deformity or garden spade deformity. Okay. In Barton's fracture, the intra-articular with dislocation, we can see, and volar and dorsal rim fracture often unstable, needs surgery. Okay. If you are seeing this image, this in intra-articular dislocation we can see in this, we can see in X-ray. Okay. And sometimes this dorsal rim with subluxation of the corpus also. Next, Chauffer's fracture. This Chauffer's fracture is a radial styloid fracture, direct blow or avulsion, and it's isolated with radial styloid fractures. Okay. It's, if you're seeing this image, you can see this area you will get mostly fractures. Sorry. Yeah, so you can easily understand this image here. Colles fracture is like first, that means fall on outstretched hand, outstretched wrist or hand. Here we can see dorsal angulation, and this is very common fracture. Next one, Smith fracture, also known as volar fracture, because we can tell that is reverse Colles fracture, and because of fall on flexed wrist, and we can see volar angulation. And next, Barton's fracture. In this Barton fracture we can see dorsal. Okay, in dorsally like volar or dorsal rim with subluxation of the corpus. Next, clinical features. In clinical features, mostly we can see pain, swelling at the wrist, and deformities like dinner fork, Colles fracture, garden spade, Smith fracture, and decreased wrist range of motion, and check medium nerve functions, risk of carpal tunnel syndrome. In investigation, I already shown many X-rays based on the fractures. In X-ray wrist, we have to do anterior posterior view and lateral view, and we have to check every time radial height and radial inclination and volar tilt and ulnar variance and distal radial ulnar joint congruity and articular involvement and comminution. This everything I explained already before, so I am not going to teach another time. Next one, CT scan. In CT scan for intra-articular or complex fractures or pre-op planning, we have to do CT scan. And MRI, if it's very rarely needed, if we are suspecting any soft tissue injury or triangular fibrocartilage complex injury suspected, then we have to do MRI. Now management. In non-operative, first indications like minimally displaced fracture, like non-operative things, unstable extra-articular fracture and low demand elderly patients, then we are not doing any non-operative. Then after in methods we can use closed reduction and below elbow cast for 3 to 6 weeks, and we have to weekly monitor with X-ray for redisplacement, and we have to do rehabilitation after cast removal. Why we have to do rehabilitation means, because of that fracture mostly that patient will not get pronation and supination movement properly. So for that thing we have to encourage the mobilization, and we have to acceptable alignments. If radial height loss less than 5 mm means, we can do with non-operative, we can fix that thing. And dorsal angulation less than 10 degrees, in articular step off like less than 2 mm, in radius inclination greater than 15 degrees means we can think non-operative things. In operation, in surgical management, indication in intra-articular and unstable fractures, failure of conservative treatment and open fracture associated with neurovascular injury or avascular necrosis and irreducible fractures, then we have to do surgically, we have to do management. In options, we can think about open reduction internal fixation like volar locking plate. This is the most common we are using in our hospital settings. Next one, external fixation like ligamentotoxis like for comminuted or for open fracture, and we can use some percutaneous KYs and fragment specific fixation. In post operative care, we have to follow the elevation and eyes for swellings and early finger and shoulder motion, and we have to monitor for carpal tunnel syndrome, and we have to begin with the wrist range of motion like after surgery 2 to 4 within 2 to 4 weeks we have to begin wrist range of motion, and we have to strengthen the muscles and tendons after 6 to 8 weeks. In complications, I divided into 2 types like early complications and late complications. In early complications, we can see compartment syndrome and median nerve compression and skin necrosis like because of tight cast and loss of reduction. In late complication, we can see malunion most common, and distal radial ulnar joint instability and post traumatic arthritis, stiffness and tendon rupture, and CRPS means complex regional pain syndrome. Okay, so here especially this is the tips for you for your hospital field. Always we have to check after fracture, always we have to check neurovascular status, and we have to mention it's open or versus it's closed fracture. These things I am telling you about for your exams, and in ASCII settings we have to mention these things, and we have to understand the radiological assessment of reduction, restoration of 3 key angles are less than 2 mm step off, and we have to know your classification properly and be ready to describe surgical steps in volar plating. Okay, and yeah, so I covered everything in distal radius fracture. If you have any doubts, you can ask me in comment section, and like, say, we will meet in our next video. Take care. Bye bye.